Okay, so there it is. There it is. The goals of care are preventing complications and optimizing quality of life. We cannot save a patient from heart attack and stroke and make his quality of life miserable. We have to improve complications also and make quality of life better as well. Now, looking at the end result, the complications, a large proportion of patients with diabetes have CV disease. 1/3 of patients with diabetes will have cardiovascular disease at any point in time during their lifespan. 40% of the diabetics will have chronic kidney disease at any point in their lifetime. So when we manage diabetes, we are looking at the end goal, preventing these chronic kidney disease and cardiovascular disease. And that is why we always say we are not only treating diabetes, we are treating the cardiovascular kidney metabolic syndrome. We have to treat in a manner which treats diabetes, the kidneys, and the cardiovascular disease, because that will serve the ultimate purpose of preventing complications in diabetes. And if you see the pillars of management of American Diabetes Association, there were 3 pillars initially: glycemic management, blood pressure management, lipid management. And then the 4th pillar came in, which said use agents with cardiovascular and kidney benefit. And that is the most important thing. And you all know we use SGLT2 inhibitors and GLP-1 analogs when cardiovascular disease comes in. So my question to you all is, if somebody does not have cardiovascular disease, will you still prefer SGLT2 and GLP-1? Yes or no? Yes, because ultimately he will get the cardiovascular disease. Great. Early combination therapy. So what used to happen earlier on, when diabetes used to set in, we used to start with metformin, right? But look at what the American Association of Clinical Endocrinology says. Look at on the right of the screen, the red box. It says if A1C is more than 7.5% at the start 2 agents right at the beginning. Or if A1C is more than 9, you start 2 or 3 agents in the beginning straight away. Or if the goal of HbA1c, what is the usual goal of HbA1c? Fantastic, great audience here. 7%. So if A1c is more than 1.5, above your target, then you can start 2 or 3 agents straight away. And these are other guidelines: ADA, ACE, European Society of Cardiology, Pakistan Endocrine Society, and all would say use combination treatment if your goal is 1.5% above your target. Now, what is the average presenting HbA1c in your clinics? A newly diagnosed diabetes, what is the A1c that he comes in with? What is the A1c usually? 10, 8, 11. Look at these 2 surveys. They say, okay, it is 8.56. Now, if I say the cutoff is 7%, 8.56 is already more than 1.5 the cutoff. This means that in our population, we have to start with a dual agent and even a triple agent if the A1c is more than 9% at the start. So initial medication choices in type 2 diabetes. What is the gold standard first-line medication in diabetes? Fantastic, metformin. What should be the second-line medication according to preventing complication theory, right? Fantastic, great. Oh, I don't need to do anything. You already know everything, right? What should be the third-line agent in type 2 diabetes? GLP-1 analog, DPP-4, Professor is adamant DPP-4. So these are the first 4 agents that we are using in type 2 diabetes. Now, if I ask you, which is the odd one out? Odd one out is not the bad one, it's just the odd one out. Which is the odd one out in this? It's already not here. It's already not here. It has its own role. But the odd one out here is the GLP-1 analog. Why? 40% Pakistanis are not earning 17,000 rupees per month. GLP-1 analog, even with the local production, is 8 to 10,000 per month. So that's the odd one out. Most people will not be able to afford GLP-1 in Pakistan. When we manage diabetes, we have to see the holistic picture, right? So, of course, it's a fantastic medication. You need to prescribe, you need to offer patients, but I am talking in a holistic approach. So now we are left with 3 medications at the outset: metformin, SGLT2 inhibitors, and DPP-4 inhibitors. And here comes the concept of the triple combination in diabetes management. Now I'll go through one by one, I'll go through all these 3 medications, and then I'll again mix them together to make the triple combination and tell you the benefits as well. So empagliflozin, already the speakers before me have given some review. So this was the beautiful EMPA-REG trial which shows that empagliflozin reduces 3-point MACE, it reduces cardiovascular death, hospitalization for heart failure and all-cause mortality. You all know this. I don't need to go into the detail, right? Again, the EMPA showed that treating 1,000 patients with type 2 diabetes at high CV risk with empagliflozin for 3 years saves 25 lives, save 22 CV deaths, prevent 14 hospitalizations for heart failure with 53 additional genital tract infections. But these infections were there in the Western society where there was dry hygiene. So Pakistan conducted its own study in 12 centers, the Safe Park trial, where we recruited 250 patients, and we saw that in our society where there is mostly wet hygiene, and it was done in Muslim population, it was seen that there was no increased genital tract infections or UTI in this part of the world. And then empagliflozin's role in heart failure and CKD, many trials, Emperor reduced, Emperor preserved, EMPA kidney. I have 15 minutes, I want to go into the detail, but I can't, of course. It's a whole journey. Empagliflozin started as a treatment for diabetes, and now it's a treatment for CKD as well, and now it's a treatment for heart failure as well, and not only reduced, but also the preserved ejection fraction heart failure. And that's the journey, 2014 to 2023. This is the journey. Approvals for diabetes, heart failure, CKD, and we know it's a magical combination that we have. Linagliptin is the second medication, right? So linagliptin in this combination is the second medication. How many of you use linagliptin in your practice? Okay, and EMPA-lina combinations? Fantastic, great. So linagliptin, again, what you want is a second-line medication. And Zahid is here. So linagliptin reduces HbA1c, low risk of hypoglycemia, cardiovascular safe, renal safe, weight neutral, no increased hospitalization for heart failure, and once daily dosing. It's a fantastic medication and vast experience. In Pakistan, we have been using DPP-4 inhibitors for the last 17, 18 years, and we know hardly there are any side effects that you can attribute to the DPP-4 inhibitors. And then the Carolina and the Carmelina trials. I won't go into the detail, but just to highlight, in Carolina, linagliptin was compared against glimepiride, and it was seen that there was no increased cardiovascular disease with linagliptin compared to glimepiride. And the same study showed that even the cardiovascular mortality was same with linagliptin and glimepiride. And then the Carmelina trial, another huge trial, again showed the same thing, that cardiovascular disease does not increase with linagliptin. It was cardiovascular safe. And then the renal safety. I mean, this is the only SGLT2, only DPP-4 inhibitor where you don't need renal adjustment. 5 milligram once daily is the dose, whatever the GFR, you don't need to adjust like you do with sitagliptin and vildagliptin. Coming up to metformin, the gold standard medication of diabetes. Now look at this. The slide was small and the societies were so many. World over, the societies recommend metformin as the first-line therapy in type 2 diabetes, including the Pakistan Endocrine Society. But the biggest side effect with metformin is the GI upset. But since the XR combination came in, we were fortunately relieved to get away with those, or very much get away with those GI side effects. And if you see, the GI side effects with metformin are 20 to 30% patients. But if you give the XR combination, it comes down from 26% to 11%. And many of these combination medications, and especially the triple combination, uses the XR technology. So again, coming back to the initial medication choices in type 2 diabetes, and remember we need to start with the combination therapy. We have metformin XR, empagliflozin, and linagliptin. So what should we do? Should we start 3 medications in one go? 1, 2, 3 tablets? The patient will go away. Your patient will come to him, and my patient will go to Professor Zahid, right? And he'll do the same thing probably. He's going to give a triple combination. So here comes the goal with triple combination. So now, when we have to give combinations, then we need to just add up the tablet and give 1 tablet rather than 2, 3 tablets. So you do the best job. You have given the best medication, but is non-adherence a problem with type 2 diabetes medicines? Yes or no? Yes, it is. So again, if you see, very nice study. It showed in the community only 1 in 3 with type 2 diabetes had adequate adherence to oral hypoglycemic drugs. And it says 1 tablet per day administration was associated with greater adherence rather than multiple tablets. So what we should do, you write the best prescription, the patient doesn't take it, 2 out of 3. What should you do? Of course, treatment adherence can be improved with combination pills, less frequent dosing, fewer adverse events, and reduced cost. And that is where the triple combination comes in. It was approved by FDA in 2020, but in Pakistan, we are having it in 2024. That's also not too bad. The AMPA-LINA metformin XR combination to improve glycemic control in adults with type 2 diabetes. And this is the tri-layer tablet with immediate release, empagliflozin and linagliptin, and a core of metformin XR to be released gradually over the next 24 hours. And we see that if we add, somebody's taking metformin, and if we add AMPA and LINA both, the A1C gets reduced by up to 1.8% compared to just 1 to 1.2% when we are giving AMPA or LINA to metformin, rather than giving both AMPA and LINA with metformin. And 60% of the patients have a controlled HbA1c when they are on triple therapy, compared to only 32% when they are taking either metformin or LINA or metformin or AMPA. So triple combination, of course, has its own benefit. So 3 tablets versus 1 tablet, you give triple fixed dose combination, low regime complexity, easy to take, 1 tablet, right? High medication adherence and improve glycemic control. I still have a few minutes left, so I'll just do a couple of cases if you allow me. It's just 12 minutes up till now. I've got 3 more, right? So, okay, so question number 1, you all are with me or no? Yes or not? We have 3 minutes, we need to make the best use of it. 41-year-old Mr. Salman, school teacher, type 2 diabetes for 3 years, takes metformin 500 milligrams twice daily. Sab mere saath hai? He exercises daily and is compliant with diet. He is obese, BMI is 29, GFR is 59. A1C 8.3, uncontrolled, controlled. Fantastic. He has no micro or macrovascular complications. He doesn't want to take many medicines like most of our patients, and he's not been compliant with the clinic follow-up visits. He's on metformin twice daily. A1C is 8.3%. Write down, okay? What medication change will you make? Give metformin XR plus SGLT2 inhibitor. Give metformin XR or DPP4 inhibitor twice daily. Or give metformin XR plus SGLT2 in the morning and metformin and DPP4 inhibitor in the night, which I used to do before the triple combination, right? And fourth, you give the triple combination, metformin, DPP4, SGLT2 inhibitor once daily, or add insulin to metformin. What would you like to do for this patient? Fantastic. Fourth, why? तो पहले हम अलग-अलग देते थे, वो एक तो मैंने पढ़ा दिया और सेशन भी यही. So the whole point is that you give one medicine, पहले वो metformin 2 बार ले रहा था, आपने एक tablet कर दी, और एक tablet करके A1C भी 1.8% नीचे ले आए, 8.3 से 6.5. So again, going on to the next and the last case, 59-year-old Mrs. Rehan, a homemaker, newly diagnosed with type 2 diabetes. She's obese, BMI is 30, GFR is 79, A1C is 9.1, FBS is 156. No micro macrovascular complication, newly diagnosed diabetes, right? Mostly alone at home at daytime. Son has a job and his income barely meets the expenses like most middle class people in this country. What medication will you give? She's newly diagnosed, A1C is 9.1. Would you start one medication or would you start a combination tablet to her? Combination tablet, of course. So give metformin XR once daily, metformin XR DPP4 twice daily, metformin and SGLT2 in the morning, metformin and DPP4 in the night, or a triple combination to start with once daily in the morning, metformin and sulfonylurea twice daily. What would you do? Oh, So again, you again know this is 9.1. Somebody has more than 9, you start with 2 or 3 medications straight away. You go with triple therapy. Will that cause hypoglycemia? Yes or no? No hypoglycemia. So again, we know the cost of glimepiride is actually similar to the triple combination, and we don't want hypos in this patient because of glimepiride. So my last slide, triple combination, complementary mechanism of action, reduced pill burden, better adherence, improved satisfaction, lower cost, and ultimately you prevent complications and also improve the quality of life, in this case by reducing hypoglycemia, reducing the cost, and improving the weight as well. Thank you very much for your patient listening.
Thank you, sir, for a lively and interactive session. Now we move on to our last speaker of the session. I will request President Primary Diabetes Care Association Pakistan, Professor Dr. Zahid Mia. He will be talking about a novel drug in the management of type 2 diabetes mellitus, ameglimin. Please welcome Professor Dr. Zahid Mia.
Assalamualaikum. Thank you very much. वो कहते हैं ना मुनीर आज़िज़ ने कहा है अक्सर देर कर देता हूँ हाँ तो अक्सर देर कर देता हूँ तो ये अहमद शहजाद तुम्हारे लिए हैं कि कल बहुत लेट हो गया आने में and I heard about this gorgeous awesome meeting you had last night so तो वही बात आ गई कि अक्सर देर कर देता हूँ ऐसी बातों में What is this? Thank you very much again. So देर तो हो गई लेकिन कोशिश है कि यहाँ देर ना हो काजी साहब आपने 25 मिनट मांगे लेकिन आजकल काजी को टाइम नहीं मिल रहा तो इसलिए आपको भी टाइम नहीं दिया गया तो इसलिए मैं भी यही सोच रहा हूँ कि शायद मुझे भी इतना टाइम ना मिले प्रोफेसर जमाल साहब बैठे हैं और मुस्कुरा रहे हैं कि ये कहता तो यही है लेकिन करेगा वही जो करना है तो खैर बहुत गर्म खबरें हैं मेरे पास सो देयर आर मैनी हॉट न्यूज़ मैं कराची से आ रहा हूँ तो कराची में तो हर वक्त गर्म खबरें रहती हैं although the Islamabad is the markaz but still the Karachi is the center of the hottest news in all variety of the news is I got few of them जो बहुत गर्म है कुछ ज़रा कम गर्म है और कुछ अब ठंडी होती जा रही हैं तो अगर आप कोई अकेले में मुझसे बात करना चाहे तो कर सकता है so and then but my dear friends and colleagues for the past 2 decades in the field of diabetes there are some hot news as well and we are talking more about the molecular basis of the pathophysiology of type 2 diabetes. And who remember this tiny little organelle in the cells? क्या ख्याल है याद है ना सबको जवानी याद है नाम क्या है इसका mitochondria. So this little tiny organelle in every cell and hundreds of numbers in the hundred of numbers is the talk and the hottest topic nowadays in the molecular level of type 2 diabetes in terms of pathophysiology and you can see that this has got a different I'm not going into the detail of its anatomy and what are the different parts, but what I will discuss in this talk, what are the mitochondrial function and dysfunction, not in detail of course, the mitochondrial function in the diabetes and the diabetes core defect and the new molecule which is come around and the development of this new molecule, the imiglymin, and its approval, the imiglymin and the heart, and take-home message. What I will not discuss, this is also important, is the other new molecule. So, मुझसे उनके बारे में ना पूछें. So, वो कहते हैं ना मुझसे उन बातों का ना पूछ जो मैंने की नहीं है. तो इसलिए. So, let's talk about the mitochondrial dysfunction in a small way. And we all know that the mitochondria is an intracellular organelle which is present in almost all eukaryotic cell. And one cell contains hundreds of mitochondria. And these mitochondria are important for producing ATPs which is vital for all living organism. And the mitochondria have their own mitochondrial DNA, and there are several copies of the mitochondrial DNA, but it has got a very poor repair mechanism. And there are three main functions of the mitochondria. आप लोग बोर नहीं होइएगा देखें, और चेहरों से लगना शुरू हो गया, कुछ ग्रिन सी आना शुरू हो गई, लेकिन बोर नहीं होइएगा. So there are three main function, और हमें सबको पता है कि mitochondria ATP generate करते हैं, they're producing the ROS, the reactive oxygen species, and the apoptosis. And it has got an outer membrane and an inner membrane and a matrix, and all three structure has got a very important physiological action to do. And we know that the mitochondria are the powerhouses of every cell in producing ATPs. And you can see that there are many ATPs produced by this mitochondria in one cell, which is needed for every function of the cells. Without, यानी कि वही बात हो गई कि अब जो ATPs हैं, वो आजकल डॉलर की तरह हो गए ना, कि डॉलर के बगैर जिस तरह काम नहीं हो पाता, तो उसी तरह आपको बिल्कुल कोई काम नहीं होता ATP के बगैर. But it looks very simple that yes, the mitochondria produces ATPs, and there are pathways of producing ATPs. But my dear friends and colleagues, जैसे आप ड्रामे देखते हैं और फिल्म देखते हैं, लेकिन इस ड्रामा और फिल्म के पीछे असल काम करने वाले उस पर्दे के पीछे होते हैं. सो नाम तो मेरा है, लेकिन मेरे पीछे काम करने वाले बैठे हैं मेरे सामने ही. So the craftsmanship behind the camera is very important in having any productive work, and this craftsmanship is done by this electron transport chain. And this electron transport chain, if you can see over here, which is anchored by the inner membrane, and आपको याद है ना, inner membrane, एक outer membrane है, एक inner membrane है, और उसके साथ साथ जो है वो matrix है. So the inner membrane anchoring these important complexes, which are the complex 1, 2, ये जो आपको red नजर आ रहे हैं, these are the complex 1, 2, 3, and 4. And these complexes are important as they transport the electron, which are produced from the